very much. So my name is Des Murphy. I'm a consultant in respiratory medicine down in CUH, and I'm the current clinical lead for respiratory medicine nationally. And it's a great honour, and thanks very much for being asked to present at this. And as Martin had said, we've just recently become involved in this initiative, and with the new living lab in CUH, and it's great to be involved. I'm going to talk to you about respiratory rate, which some of the clinicians will be very much aware of what it is, but what we teach students is that it's obviously the number of breaths that a person takes in a minute, and that patient is essentially in trouble if they take too many breaths or they take too few breaths. And it's listed as one of the vital signs, which will give you an indication of how important it actually is. It's included on the news score that Lucy mentioned earlier. And just to give you an idea of how important respiration is in the news score, the first three parameters, respiratory rate, oxygen saturations, and the required amount of inspired oxygen, are all dependent on the respiratory system. So essentially 3 out of the 7 parameters on a news score or an iNews score is dependent on the respiratory system. So it is truly a vital sign. And if you look at this is the National Clinical Programme Irish Thoracic Society scoring system that was used during COVID nationally. And in this, it's even more important. We don't actually use blood pressure or temperature when we're scoring severity of COVID and the need for escalation of therapy. We simply look at how much oxygen somebody required, what their oxygen saturations were, and what their respiratory rate was in order to determine whether we escalate treatment or not. So how do you measure respiratory rate? You think of something that important that there'd be a very sophisticated method that we'd measure it. Well, actually, there's not. Currently, somebody stands at the end of a bed with a watch and counts. And then if you count to 30, you multiply what you get by 2. And if you count to 60, obviously that gives you your number of breaths per minute. Now, anyone who's on the call here will be quite aware, if someone is at the end of a bed looking at you and watching how you're breathing, it affects how you breathe. So it's actually quite a difficult thing to do, to sit there and breathe normally when there's somebody staring at you. Now, we would try and teach medical students, etc., tricks when they're going through medical school, for example, to measure someone's pulse rate and at the same time subtly count what their respiratory rate is. But it's currently done manually. So that's very much a deficit in it. So Myles, who's on after me, developed this system, the Respirosense, which is for continuous monitoring of respiratory rate. It's a wearable continuous respiratory rate monitor. It operates by measuring movements of the chest and abdomen to calculate the respiratory rate. And the approach enables this thing called motion tolerant measurements, and they then produce reliable results which can trigger timely action. For example, tell a doctor that they need to do an ABG. It can talk remotely to a single display so that the respiratory compromised patients can be assessed should they decompensate in between vital sign observations. So it's a very useful system. Sorry, no, I don't know what's going on there. That's not moving on for me for some reason. There you go. And during COVID-19, it was deployed in Beaumont Hospital. And what they found is over 41.6% of the early warning scores changed when the Respirosense movements were used, which is extremely dramatic and would cause a little bit of, would be cause for concern. Now, the manual respiratory rate obviously can impact the accuracy of the early warning score. They showed that here. And the patients were compensated with increased respiratory rate can actually mask the signs of respiratory failure, such as hypoxia. So, for example, you can increase your respiratory rate in order to maintain a normal level of oxygen saturations for a certain length of time. So the respiratory rate itself is a more sensitive measure of respiratory failure, and in turn, that's more accurately measured if you use this system rather than a manual system. The cameras are actually over my presentation. The respiratory rate with PaCO2 are strong markers of respiratory compromise, and actually earlier than the SpO2 measured desaturation, which is what I just alluded to. When the respiratory rate was continuously monitored, the future events of hypoxia and pyrexia occurred on average about 12 hours after the patient's respiratory rate became elevated past 24 breaths per minute. The manual respiratory rate showed no prognostic power. So there's a deep flaw in method in the way we're currently monitoring patients, whereas the respiratory, this monitor is a far better, or appears to be a far better system, at least in COVID patients. So what about other respiratory disease? So this really actually just looked at COVID. So while manual respiratory may cause problems with early warning scores, conversely, and this is, I think, an important point, is that all the early warning scores, including the new scores, were actually validated with the manual respiratory rate. So what you have to ask yourself is if there's a systemic error in all of the scoring systems that we currently use. That actually, for example, if the manual respiratory rate overestimates your respiratory rate by, say, 20%, that's inherent flaw that's built into the early warning scores. And this is a very good opportunity to try and address that. This is our ward in CUH, and we're very proud of this respiratory ward. It was it's a state-of-the-art ward. It's Ward 5B. It was opened back in 2015, and it was developed in conjunction with Build for Life, who are a cystic fibrosis charity. And to say that it's top spec, I mean, people from abroad have come back and come over to examine the ward. At the time, it's a negative pressure ward. It's got state-of-the-art microbiology and decontamination systems. There's 8 negative pressure rooms on it. UCC and the Tyndall put in an awful lot of equipment. So we're very proud of it. But in addition, we're very used to innovating and putting technology through this. So it actually seemed like a very good place to turn into a living lab. It contains 20 beds. 4 of them are high dependency. We've 8 centrally monitored beds, and we've 8 side rooms. And just to give you a feel, these are the side rooms. So I've stayed in smaller hotel rooms than this. So they're very much state of the art. And if you look at the monitors, they're actually TVs with internet access, with inhaler instruction videos, with educational things. They can get access online. They can stream. So it really is. It's a great system. This is the respiratory system. So these are the monitors here, and they're taped to somebody's abdomen, and they calculate the respiratory rate, which is then fed back to a monitor, which is on the nursing station. So the nurses have access to it, the same as they would normally have to blood pressure and pulse rate in a high dependency unit. So to date, we only started this over the summer. We've 49 patients put through the system, 51% male. About 53% are over 65 years. The average duration of wearing the monitor for each patient was 129 hours. These were the different diagnoses. So across the spectrum of respiratory disease, 17 with COPD, 12 with asthma, 14 had a pneumonia, 3 had pulmonary hypertension, 3 pulmonary fibrosis, and 2 developed pulmonary emboli while they were inpatients. So there's an overlap between some of these numbers. So if you think they don't add up, the ethics to interrogate this data has been submitted and is approval hopefully pending in the next 2 to 3 weeks, which will allow us to interrogate the data further. So I'd just like to acknowledge 5B. Obviously, we have a sister there who's very proactive in this, Deirdre Byrne, who does all the administration for this project, my registrar, Dr. Anne-Marie Sweeney, who's taken this on as her project for the year with me, and obviously PMD and Respirosense. And I'm going to hand you on to Myles, who developed the system.
So following up from this, thank you for introducing myself. So Respirosense has been in constant iterations and development since the company's incorporation in 2011. The technology was first developed in 2015 and commercialized, and usability, interoperability, and security enhancements have forged it into a scalable innovation that is currently being used in Beaumont Hospital in the respiratory ward there, and indeed in Cork University Hospital in the cystic fibrosis ward. 5B. But what I just love to highlight on is the journey of first engagement and actually making a success of a pilot or a demonstrator. For us, it all comes down to one thing, and that is the why we're doing this. If this is just a technology interest, that's absolutely fine, but it needs to be defined as such. But if this has real clinical utility, and it affects multiple stakeholders, from the executive of hospitals to the frontline team to the IT providers in the hospital as well. Everyone needs to be brought in to ensure that we know what success looks like. So for us, carefully articulating the why is crucial. So in Beaumont during the crisis, the why was very clearly defined. They wanted telemetry monitoring to protect frontline staff. They knew the value of respiratory rate if done accurately, so they wanted to put their scarce resources to the right patient at the right time, and develop that in such a way that they can ensure that every patient is treated safely and effectively. And in CUH, it is all about something exactly very similar, but moving away from COVID, looking at the other respiratory conditions that Des alluded to earlier on. So that's really our why: precision healthcare, right patient, right care, right time. And the who is the next question. So Des leads the way in CUH, but his team in 5B, the clinical nurse manager, Ita, and her team, along with the estate and the biomedical engineering team, Bernard and his team, these are all elements of the implementation of Respirosense, whether it takes 1 week or 1 year. Everyone needs to be involved and understand the why we're doing this. And then the what. We have a very clear set of objectives. The 2 goals were very clearly laid out. Number 1 was, could it be implemented within a new ward environment? Could the nursing staff adapt to using it? Could patients tolerate it? And the second objective was, does it have additional clinical utility outside of COVID patients? And as we alluded to, can it timely trigger ABGs so that the right patient can get the right assessment at the right time? Just the next slide there, please, Ross. Thank you.
Bear with me now. It seems to have stuck. No, excellent.
That's wonderful. Thank you. So in terms of implementing this is a wireless solution that does use networks. So the 2 key components during the implementation phase are the IT teams and the estates teams of the hospital. But what we essentially have is a modular design that allows it just to be plug and play. So from the get-go, we did a ward round walk. We looked for power outlets, PoE outlets, internet outlets, and the ideal positions of our repeater system. So what you see there is a very typical diagram where we have 1 monitor which is centrally mounted. We have a number of patients around the ward who's actually wearing Respirosense, and this is advertising every 3 seconds the latest respiratory rate and if any alarms exist. And that's all being controlled and networked through our servers via the hospital's IT system. So just the next slide there, please, Ross, to finish it off. So basically, that all seems very complicated, but we were able to do this incredibly efficiently, both in Beaumont at the peak and in terms of CUH, then when the decision was for it to be a demonstrator site. This really pertained in a 1-day site audit. Where were we going to put these? Where do we need extra plugs? Where do we need extra PO? For the size of the 5B ward, we needed 3 repeaters that would cover the entire space. We needed an additional day then for training frontline staff on the clinical protocol, the who gets it, why do they get it, what to do when it alarms. And then the next day was all about just go live. First patient recruitment, application, PMD from the peripheral supports in terms of ongoing training, ongoing on-site support, both in terms of the clinical application of the product and liaising again with all the stakeholders, whether it's IT, estates, or the executive. But these speedy installations, yes, absolutely, COVID has spearheaded and accelerated the ease of these innovations to be adopted, but really having a clear message, a clear intent as to the why, understanding what the what, and understanding what the who were, made us a success.